So, good afternoon, good morning, good evening, everyone, wherever you are. My name is Dr. Zipporah Ali. I live and work in Kenya, and I would like to welcome you to this session. Am I the one who's doing the welcome, or is it Charles? Anyway, I think I'll continue. So I'd like to welcome you all to this session. This in Kenya, it's afternoon, evening, which is a series of pediatric sessions that we've been holding, and it's actually our last session for this year. And we listened to other experts the other time, and now we are going to be listening to two other experts for this evening. And I'd like maybe just to give a brief of the two experts we are going to be listening from. We have Dr. Justin Becker, he's a pediatric oncologist. Is also involved in children's bereavement. Let me just read it because it's long. He is intimately aware of the distress experienced by children with advanced cancer in their communication and end-of-life bereavement issues surrounding their disease progression. He's also the current chief of the Division of Quality of Life and Palliative Care St. Jude, and he's also a founding member of the Quality of Life for All at Jude Bereaved Parents Steering Council. He has received a number of awards in his work in terms of pediatric palliative care, and is also recognized as an international expert and leader in the field of pediatric palliative care oncology, as well as a highly sought after speaker and mentor with a track record of success. I think we shared his full CV, and so maybe he'll tell us a little bit about himself. He'll be our first speaker, but I would also like to introduce our second speaker so that we don't have a break in between. Our second speaker is Elizabeth Kabuthi. She's a medical, she's actually a sociologist. She's done sociology and is currently doing her master's in sociology. She's a medical social worker working at Moi Teaching and Referral Hospital in pediatric oncology. She's very passionate about children and also supporting bereaved families. She's also a member of the Certified Child Life Support Specialist, and actually is a pioneer in this field. And she's also the president of the Child Life Association of Kenya. We'll be listening to both speakers, and the reason why we are concentrating on pediatric palliative care is, for most of you, for example, if you're living in Kenya, you understand that we have not done very well in the field of children's palliative care. We've done quite well in adult field, but in the children's field, we have not really done very well because of misunderstanding of what palliative care is, and because of the fact that our pediatricians, and Dr. Justin, I wish you could talk to a pediatrician one of these days, don't think children need palliative care. They think when you give a child palliative care, you are actually, when you refer a child to a palliative care service, you are giving up on that child. And we know that we expect children to live, to outlive their parents and all those things. So when they think that you're sending a child to palliative care center, they will not really be very happy about it. So we have about, I think only about less than 1% of the patients we see in palliative care in Kenya are children. Most of them are adults. But the good thing is that our national hospitals, Moi Teaching and Referral Hospital, Kenyatta National Hospital, have fully integrated pediatric palliative care. This is where we have most of the oncology pediatric children in those particular hospitals. So there is a bit of improvement, but we need to focus a lot on advocacy at a national level to have children be able to access the services they need. So I will not talk more about this. I'll just hand over the session to our two speakers, and we'll come back later on and have some questions sessions. Dr. Justin Becker, the floor is yours now. Maybe you'll start with the session.
Thank you so much. It is such a pleasure to be here with you all. This is such a vital topic, and in our brief time that I'm going to have with you and that we'll be together today, I'm going to be speaking about strengthening pediatric palliative care as a component of comprehensive care, and a comprehensive high quality care, I would say. And our objectives for the day are to talk about pediatric palliative care as a response to suffering. I'm going to talk a little bit about strategies for implementation and integration of pediatric palliative care. And then I'm going to talk about multidisciplinary collaboration. And I'm so grateful to be sharing the floor with Liz and be speaking today together. So that koala that you see there is because our team is called the Quality of Life for All team. And here is our team from St. Jude and the Quality of Life for All kids. And I want to focus on a few things here. You see that palliative, I'm sure you have learned in the past that palliare, the word for palliative, means to cloak or to cover, to be this extra layer of support. And you can see for us, that means this koala outfits or our ugly Christmas sweaters for my family. But I want to focus in on a really important word also, which is compassion. And compassion literally means com and pati, to suffer with. And so I want to talk about suffering as the disease that we attend to, or the disease that we treat in palliative care. And this is, as we know, this is from Edvard Munch. And this year I actually was able to go to the Munch Museum. And so this is a little bit of my funny side. I'm not able to spend too much time laughing with you, but we don't always only talk about issues related to suffering. We also talk about hope and joy in palliative care. But suffering is the disease we treat in palliative care. And we think about the concept that Dame Cicely Saunders taught us about total pain, but we really also have to think about the concept of total suffering and how patients suffer from certainly pain and other physical symptoms, but also psychological, social, cultural, and spiritual issues. We lost a pioneer in palliative care, Eric Cassell, but he taught us that suffering is a specific state of distress that occurs when the intactness or integrity of the person is threatened or disrupted. And it lasts until that threat is gone or integrity is restored. The meanings and the fear are personal and individual, so that even if two patients have the same symptoms, their suffering would be different. And so when we think about the concept of suffering, we have to realize there are visible threats and there are invisible threats. And we have to think about targeted interventions and global interventions. And we're going to walk through how to integrate some of these interventions. As Professor Downing mentioned to us, and as we know, the WHO thinks about palliative care as a holistic approach that improves quality of life, that works to address suffering. And it's clearly proven to improve quality of life and psychosocial outcomes, as well as caregiver burden, and it may well reduce overall cost while improving other key quality metrics. I want to tell you, though, that there are some really critical tools that I think are underspoken of as we think about palliative care. And these tools are actually tremendously simple, and they'll make a huge difference if you go and employ them in the way that I'm going to talk about them, even after you finish this session today. The first is our ears. My grandmother said, God didn't give us 2 ears and 1 mouth for no reason. We have to be able to hear and listen and be willing to be changed by what we hear. We have to use our heart, and I already talked about compassion, and be willing to suffer with our patients and families. And we have to use our team. And if we're truly functioning as a team, we have to deliver holistic care. We also need to make sure that we're involving the child. And sometimes that gets people all excited. What do you mean? That's not what we do in our culture. No, we just need to engage the child and bring them into the process in whatever way may work in your culture and in your setting. Just involve them just a little bit more. And then we have to make sure to realize that communication is the cornerstone of everything we're doing. In fact, our words matter, and communication is the procedure of the hospice and palliative medicine clinician. In fact, I would say it's one of the procedures of all of our works as clinicians. Communication is all about building relationships, and relationships are built by making sure that we address each of these aspects of communication, providing validation, helping families make decisions, enabling family self-management, exchanging information, managing uncertainty, responding to emotions, and supporting hope. And the better that we can do that, the better we actually will improve outcomes. It really is this skillful combination of role. It's not, some people talk about things like the palliative phase. That's terrible. No. Palliative care needs to be integrated throughout. We have to be dedicated to discovering and committed to caring, bringing those together. And I'm so grateful because here at St. Jude, I really feel like this is what we're doing. We're working together hand in hand. I saw Dr. Catherine Lamb joining here, working hand in hand with Dr. Kath as she sees her patients and tries to aggressively treat their cancer, and we aggressively treat their suffering, and we work hand in hand to combine those efforts. So palliative care is integrated throughout. It is not a phase. It is not a component. When we talk about referring, in fact, to a palliative care team, we're actually talking about referring to a subspecialty palliative care team. The way we think about integrating here at St. Jude, and the way that I would encourage you to think about integrating, including all policies, etc., the top of this tier is a consult-based service. That's when somebody else asks the palliative care team to be involved. The second tier is when we think about what are the specific populations, where should palliative care automatically be involved? At our institution, that's in our bone marrow transplant unit and with some very high risk brain tumors. We just become a part of the team and we're a part of every aspect of what we do. And so that's kind of thinking about, are there specific, maybe there's specific components of your hospital where palliative care should be a part of the program that's just there. And then the bottom tier is really where we talk about education, policy, and resources. And when we think of those issues, we have to think, how can we make everybody better at palliative care related approaches, or what we would call generalist palliative care approaches, making sure that things like our nurses here at St. Jude, all of the nurses are trained in palliative care here at St. Jude. So we want to think through that together. And so what we're really approaching is pediatric palliative oncology as a whole new field. It's where we've integrated these two spaces. And the question you should ask is, does it actually make a difference? And what we're seeing is the answer is yes, that there's an increase in subspecialty palliative care involvement. This improves quality of life. Children are more likely to have a meaningful moment at the end of life. Children are more likely to die in the place that the family wished. They're less likely to have invasive procedures, and yet they still live just as long. And there's decreased caregiver burden, and families feel heard. So it's incredible. As you integrate palliative care more effectively, it will make a tremendous difference. So I want to walk with you through a child's journey quickly here and think with you, where could palliative care be integrated? Where might we think about it? Well, here at this first step, this is at the point of diagnosis and acute decompensation. Palliative care could be involved to help with pain and symptom management. And a multidisciplinary palliative care team, including the primary team, could be thinking about coping with the new diagnosis and making sure that there's collaboration and communication with multidisciplinary team members. And we could be thinking about sibling distress. Now, this may or may not be with the palliative care team involved, but hopefully the palliative care team has educated all the other team members so that they can do this even more effectively. Then there's adjusting to new normal, where there's lingering symptoms and coordinating care and grieving the loss of the well child and anticipatory grief. Then there can be this acute decompensation and unexpected recoveries, where pain and symptoms, goal setting, comfort care initiatives, multidisciplinary support. Then at the point where there's slow or precipitous decline leading to end of life, we have to have coping and resilience that we're talking about, decisions regarding invasive technology, self-determination for the child and patient, and pain and symptom management. Have to be also thinking about grief and bereavement issues and sibling distress. And then at end of life, we have to be, this is an emergency. We have to be surrounding this family, helping them plan for death, figuring out where they want to be at the end of life, verifying decisions regarding resuscitation and aggressive symptom management, and then really providing an intensive care of the imminently dying patient. And for those patients that don't die, we need to make sure that we're maximizing their recovery and optimizing function, and we're monitoring and managing late effects. Now, what I'll tell you is, primary palliative care, so what you can think of kind of as above this line, where maybe the risk of suffering is not quite as high, this should be integrated by the primary team, by perhaps a primary oncology team or otherwise. And then subspecialty palliative care can be involved at these high risk situations. And it might be that they're involved right from the beginning, but maybe then they kind of back out of the scenario and empower the primary team to do the work. The point of this is, it really takes multidisciplinary collaboration. And when we think about multidisciplinary collaboration, we have to think about interdisciplinary care team meetings and how can we work together as primary oncologists, the oncology nurse, social worker, palliative care physician, child life specialists, and all of this. And it really takes effort to make sure that we do this well. And so as we begin to close, I put up this checklist to say, at the end of life, this is a high risk moment. And palliative care is not exclusive about end of life care, but the most important times that we work with patients and families is at the end of life. It is an emergency. It is vital and critical. And we've created an end of life care checklist to ensure that there is multidisciplinary collaboration. And if you take a picture of this QR code, you'll be able to get to our website that then allows for you to download this end of life care checklist to promote multidisciplinary collaboration. And so as I wrap up my session, we have to recognize that the World Health Organization acknowledges that palliative care is an ethical responsibility, and that it's the ethical duty of we as healthcare professionals to alleviate pain and suffering. And I was so grateful to be invited by ICPCN to work at UHC 2030 in promoting palliative care. And I know Professor Downing spoke last time, and I'm grateful for the opportunity to have been there with them promoting this palliative care integration into UHC 2030. And for all of us, we have to recognize that access to high quality palliative care is a fundamental human right. And so as I close, I want to lead you back to this spot again and think with you. So if I'm a policymaker, how can I address issues related to on-demand consult-based palliative care? Well, I have to increase subspecialty palliative care capacity. I have to help train subspecialty palliative care providers, be they physicians or nurses, people who can get advanced certification in palliative care. At that second tier, I have to help define in my hospital, in my institution, in my region, who are the patient populations that are at highest risk of suffering, and how can we integrate palliative care as standard of care. And then this third tier, how can we improve palliative care related issues such as communication, pain and symptom management skills like pain policies, etc. How can we improve that aspect to be integrated throughout the country level, throughout the region, and throughout each hospital through education, resources, and policies to ensure that palliative care is integrated from the ground up. And so as I close, I just want to invite you to become a part of our global palliative care community. And I'm very excited about this communication and discussion with you after this conversation with Liz. So thank you so much.
Thank you very much, Dr. Justin. That was really nice. We need to learn how to make our slides go the way yours were going. I like the technology, but I don't know it. But thank you very much. I think you really pointed out the need for palliative care throughout the continuum of the child's illness, from the time there's a diagnosis, that those physical needs that the child may be having, to the time when they're dying, and all the bereavement, grief support for the child and the family. I think one of the things I usually find challenging is that when a child dies, for example, we forget, or when a mother or a father or a sister or a brother dies, we forget that there's a mourning child as well. So maybe those are some of the things we'll ask about later, the forgotten mourners. So I don't know if everybody got a chance to scan that, what do you call it? That thing for scanning, to get that.
The QR code? Yeah, I can put it up later.
Code. Just for a minute so that everybody gets a chance to scan it. I've scanned mine.
Sure, I'll pop that up right now.
So all you need to do is point your camera to that, and it will take you to the website before it's removed. Just point your camera to that to take you to our website. We'll get to the questions at the end of the sessions, Felisa. So I hope everybody has scanned that thing there. Okay, thank you. So I think we'll now give Elizabeth an opportunity to make a presentation, and we'll take the questions at the end of the sessions. Okay. Elizabeth, you're on.
Thank you, Dr. Hello, everyone.
I think Morgan, you're sharing her slides.
Yes. Dr. Justin, it's always good to come after you because your shoes are quite big, and I hope I'm going to fit into them. Thank you for that enlightening session. So I'm going to present a case today about a child that I worked with on the unit. Being a social worker and a certified child life specialist, we work together with a multidisciplinary team of the doctors, the nurses, the oncologists, everyone. And so in my country, Kenya, as Dr. Zippy earlier explained, we do not have per se children's palliative care, but this is in its infancy, and we are trying to incorporate children's palliative care so that we are able to give this service, the most needed service to these children. So next slide, Morgan. So an introduction, I'm not going to read all through, you will get the slides later on, but I wanted to comment on the second bullet. The child, parents, and siblings each have unique experiences of the cancer journey, beginning at diagnosis and continuing through treatment and beyond. And when I talk about beyond, this is where palliative care starts coming in. So it's very important that the whole team is incorporated at the very beginning so that we can build bonds of trust with these families and these children. Next, Morgan. I wanted to give a brief history of the development of the Salitas Child Life Program. It began in the year 2000, and it's a funny story because there were two American visiting doctors' wives who went around the wards and they saw the desolate and the misery that the children were going through. Most of their days were spent in the wards, which are very, not child-friendly, dark and everything. And so when these doctors' wives decided to start a 2-hour play program along the corridors of the wards, and then it was amazing to see how many number of children would go to the mat on the corridor because they really felt that play was very important. So in the year 2007, 2008, this 2-hour play program became a fully fledged child life program when we started training with Morgan Livingston, who is among us today and who works with the See Hope Foundation. And she started training us, and we had a year-long mentorship and trainings, and we had the first ACLP examination outside of America in Africa, and I became among the first CLS in Kenya. Currently, we are 2 and 17 others reading towards certification. And so I wanted to comment about the importance of child life specialists and social workers because they play a key role in pediatric palliative care and bring vast experience in communication with children and families, especially because of our knowledge with child-friendly, a language that is non-threatening, and we are able to focus on family-centered approach, and that really makes us very open to the way we deal with children and their families from the onset. Next, Morgan. So I'm going to present to you my patient, initialed DY, and her name is Damakline. I have permission from her family. She was a 15-year-old girl in class 7, referred to us from a level 5 county hospital. She was an only child in the care of her grandmother from birth. Her mother delivered her while she was still very young, herself 17 years old, and so she was not able to live with her own baby. Currently, both parents, though separated, live and work in the Middle East. She had medical insurance. Her siblings were her cousins, and it was observed that they had a very special bond. The reason why I brought the issue of siblings here is notable. Dr. Zippy has talked about the forgotten mourners. Siblings usually are forgotten because many times their parents are in the hospitals every other day taking care of the ill child. And so the siblings are forgotten at home. And in such situations, some of the siblings can even have resentment feelings. And so it's important for us to take care of the siblings of a particular patient who is with us by working with them, talking about diagnosis education, talking about end of life, and even bereavement, so that they're able to be prepared well in advance before the eventuality happens. So Damakline was diagnosed with synovial sarcoma stage 4 with mets to the lungs. Surgery was not an immediate option due to the complications that she had. Next, Morgan. So in communication part, during admission, Damakline and her grandmother, we sat with them together with the oncologist, with the palliative care team, and we talked about the diagnosis. But at this point of prognosis, we did not involve Damakline because we felt at that particular time she was really sick, she was really down. So we needed to start talking about this issue as she started getting stable. So as her condition continued to deteriorate, hope was fostered considering that surgery was no longer an option. However, they were informed about the challenges around treatment due to the extensive abdominal mass and DVT after workups. So even when we started giving Damakline chemotherapy, she was not able to respond very well because of the extensive abdominal mass. Next, Morgan. So what are some of the spiritual concerns she raised? She would often remark, "Why is God punishing me, yet I served him in Sunday school? I attend church regularly and don't deserve this punishment." And she went on to ask us, why did my mother reject me as a child? Is my lack of breastfeeding the reason for my illness? At 15 years old, Damakline was quite informed. She was an educated young girl, and she would even listen to the doctors talk around her bed during the rounds. She would even look at our body language and know that things were not going very well for her. And so because she had a lot of spiritual pain, I facilitated a meeting with the chaplaincy, and she was able to have quite a number of sessions with the chaplains in the hospital. And that really helps her come to terms with her spiritual being. Next, Morgan, please. So what are some of the psychosocial services offered? I've talked about the communication. In this case scenario, I brought together the parents and Damakline because she had a lot of feelings of rejection, and it was important that we mitigate those feelings. And by the time she was leaving the hospital, they had already reconciled. It was beautiful to see that the mother was even able to come all the way from Middle East, and she spent at least 2 weeks with Damakline before she finally passed away. So facilitation by chaplaincy to alleviate the spiritual pain. And then we began legacy building from the time Damakline was admitted. This was because we could see her deteriorating health, and we needed her to understand that she was going through that period, that phase that was coming. So she was very good in doing the memory books. It was amazing to see her write love notes, thank you notes to the medical team, write things about her funeral, how she would like to be remembered. It was amazing. She had a lot, she was so much in touch with what she was going through. Shanga za ujasiri is another concept that we use, and this enables the children to tell their stories of their cancer journey. They do it in a bracelet form, and all these activities that the patients do while in the hospital are given as a package to the family when a child dies or when the child is discharged home. This enables them to understand what the child was going through while in the hospital, and it actually makes them bond with the child, with their sibling, even after they've gone. Pain and symptom control was done by the palliative care team, and then the discharge plan was also done. We gave out available options, for instance, hospice care, because we know Damakline was in the care of her grandmother, and she was so heavy, her mass was so extensive. It was not possible to carry Damakline alone. It needed a whole team of caretakers, of other healthcare providers to be able to support Damakline even for a bowel movement. So we had the options of hospice care, but grandmother and mother decided they wanted to go home with her, where they stayed for 2 weeks before she succumbed. And of course, palliative radiotherapies were offered because of this tension and the pain, which was gave a lot of relief to Damakline. Next slide, Morgan. So on this slide, you can see the young boys working on their memory books. This is a nice way to discuss with the medical team their concerns. They write amazing things on these books. They may write about their joys. They also write about their low times. And whenever they talk about a particular medical procedure that was very, very painful or very uncomfortable, then we give out that information to the medical team. This is a very important concept in part of child life. Next, please, Morgan. So some of the non-pharmacological pain relief that we offered to our patient was use of cold and warm compressed packs, which gave a lot of relief, especially because of the DVT. And massage, the grandmother was taught about how to offer massage. And of course, just touching the child makes them feel that they're important and they are worthy. Deep breathing exercises were also taught, because there are times when we discharge some patients home with morphine, but you'll find that morphine runs out and they live very far away from a hospital. They're not able to get a replenishing of morphine in time. So we teach children about deep breathing techniques, which is also helpful for their pain. Guided imagery also does the same. Music therapy is quite important because it brings along a tranquil and serene environment. This is something that we usually use in the hospital, because we know that these children are going through a lot of pain. When we just give them the music that they prefer, be it secular or gospel music, it really connects them with their feelings. Next slide, Morgan. So every time when we are working with a child, we have to consider these 5 elements of psychosocial support. I'll just go through in a flash: sense of safety, calming, be it at home or even in hospital. We have to instill a desire of hope, of good outcome, despite what their child is going through. I like the fact that Dr. Justin talked about palliative care is living. For sure, it is living. We have to instill hope till the very end. Social interconnectedness, the importance of siblings, the importance of extended family, and self and community efficacy. We know that in our culture in Kenya, so many tribes consider cancer as a bad omen or witchcraft. So we have to bring together the community so that they are able to understand what cancer is about, so that they are able to give support to this particular family that is going through this difficult journey. Next slide, Morgan. So death and dying, this was one of the moments that still really touched my heart. The Maclean was so afraid of dying. At 15 years, she had a lot of plans for her life. She wanted to finish schooling. She wanted to even become a doctor in future and help children with cancer. And every time I would visit her bedside, she was always asked, "Am I dying?" It was a frequent question. And sometimes those are questions that we are not trained to answer. And yes, and I think it's important that when we are doing palliative care for children, these are some of the things that we are going to discuss and learn more. It is natural for the families to feel afraid. It is normal for them to have so many questions. Why is God punishing me? Why is God not giving me a chance to live? And it is important to include chaplaincy so that they are able to walk with them at that end of life, stage of life. Next slide, Morgan. So in conclusion, I've talked about emotional support. Instrumental support is where we come in and help the families, be it collection of food, be it supporting the child to go for a bowel movement. For whatever reason you may want to support that child, it is an overload reliever according to Care ETSA 2004. So whatever it is that we do, be it in small doses, be it in magnanimity, that these families really, really appreciate whenever we come together and offer the support that is necessary. Next slide, Morgan. And so these are some of the children that we worked with, children who have passed through the hands at the Salitas Child program. Some of them are still with us and some of them have already developed wings and they've left before us. But for sure, they left footprints of love in our hearts. And so whenever we say this is what child life brings, because we've said that child life brings rich experience into the children's palliative care team. Communication using child-friendly, age-appropriate, non-threatening language makes these children feel wonderful. So this is what child life is, adding life into the days of these beautiful children and living to the end with dignity. Thank you.
Thank you very much, Elizabeth, specifically for sharing the story of the Maclean. I think even in her absence, she's teaching us a lot because we continue learning. And this is not just the story of this young lady, it's the story of many children, especially in Africa, who do not usually come with a late diagnosis, and the chances of treatment are very minimal. Or even if they come, even if they come to the hospital, they might not be able to access the kind of services you mentioned, the two speakers, because we have not strengthened our healthcare systems in terms of providing comprehensive care. So our two main objectives for today was to look at how we can have psychosocial and quality of life care integrated into the pediatric oncology, and also to look at what are the low-hanging fruits, what are the immediate things that we can do to improve this kind of care in our where we are working in our countries, regionally, locally, or just within your own institution. And we have quite a number of experts on this panel. The two speakers were experts in their field. We have people like Dr. Julia Downing, Professor Julia Downing, who is the Executive Director of the International Children's Palliative Care Network. I'm seeing Dr. Deborah, a pediatric oncologist. I've seen Dr. Zainab, who is speaking up. She's actually a president-elect for UICC. That is a very big position. Well done, Zainab. And many other people, Dr. Gina Chelekat, we worked with you so many years. And so I'm sure that we'll have a very good, interesting session on discussions on questions that you might be having from the two sessions or even coming up maybe with a way forward. How do we ensure that every child, like the Maclean, very, very interesting name, has access to palliative care? And Dr. Baker, St. Jude was here some time back this year. The St. Jude's team came to Kenya, and we held a two and a half days workshop in Nairobi, which actually also focused on looking at the needs of pediatric oncology, but of course palliative care was part of the pediatric oncology services. So there's a lot of learning we're learning, and I'm glad that actually we're now not working in silos. We are coming together, globally to address the issues that we believe exist in our own setups for children who need palliative care. So I'm opening this to question and answers. If you want to put your hand up, I didn't see any questions on the chat unless I missed them. But if you want to ask a question to any of our speakers, or just generally if you want to contribute, you're welcome. We have, I think, about 20 minutes or so to do this. I'm not seeing any hands up. If I miss a hand up, please, Charles.
Well, I will note, Zippy, and thank you very much, Justin and Elizabeth, for your presentations. Zippy, there is a note from Dr. Santi in the chat to ask, I have a question, how do they work with the rehab team to improve function? And then there's a couple of comments. There was one comment also from, sorry, I'm trying to scroll down, about expanding to other settings. And then I do see something that Benda's put into the chat. So first to Dr. Santi's
Yes, yes. So I'll give an opportunity to our two speakers to talk about that. I think that because the first question is done, we usually forget about the occupational and physiotherapy needs of children, which are very important also. Go ahead, the speakers, you can respond.
Yeah, so as a part of our multidisciplinary team, we have rehabilitation, actually all three types: occupational therapy, physical therapy, and speech therapy, because just as Liz mentioned, palliative care and good clinical care is all about maximizing a child's quality of life. And one of the very most important things, in fact, one of the most common statements a child will make when they are undergoing treatment for very complicated diseases is that they want to be normal, that they want to experience normal childlike activities. And many times the biggest barrier are functional barriers, things like mobility, things like being able to appropriately communicate or communicate in their best way. And so this is one of the most important things that we can possibly do to improve a child's quality of life and address suffering, and perhaps allow them to do the activities that they want to do, such as return to school, which is a very common request, or be able to do the things that they love in their community. So rehabilitation, physiotherapy, occupational therapy, and speech, absolutely critical.
Thank you very much. That also touches on Benda's question, but maybe it can be more specific. Dr. Deborah, are you still on?
Yes, I am.
Yes, your children, some of them survive after treatment. And
yes,
so
they do.
Benda is asking, how do we have any systems in place to support these children who have gone through this illness and maybe have developed complications, maybe they have lost a limb, or maybe they have some other disfigurement, and how do we, or even maybe, because the other day we were talking about preserving fertility in children and treating them, how do we have any follow-up survivorship programs in the country that take care of surviving children?
Yes, we are making sure that once we start treatment of the children, we book them for clinics for life, so that we're able to see about things like re-immunization, for example, which is often forgotten, that the children, because sometimes chemotherapy wipes out the immunity that they had received from the immunity that they had received from the vaccinations. So we are supposed to follow them up for life, even as they grow into adulthood, and to look out for complications of some of the chemotherapy that they have received, make sure that rehabilitation teams are able to offer the artificial limbs, and look out for long-term complications. At least increasingly, we are having more and more fertility specialists in the country, where sperm banking can be done, where even egg banking can be done. So slowly by slowly, if we start speaking about these things and making sure they are done, and we have close follow-up with all our survivors, we can be able to make sure that they have quality of care even as they grow into adulthood.
Thank you. That's important because otherwise these children will be left without. And I think one of the things we also need to focus on in support groups for these children, peer support groups play a big role in this kind of care. So I'll move, Dr. Zainab, you have a question, your hand is up. Can you ask your question, please?
Hi, hello everyone. It's a pleasure to be here. Fantastic presentations and very helpful ones. I just wonder if the two presenters coming from different aspects of the world have anything to say about the differences in accepting palliative care. For us, it's not a very developed area of care for any illness and even cancer patients because a lot of them don't survive and we just don't have that system very well in place yet. And I agree that we need to improve the quality of their lives and we need to do more, and it's one of the things we've been doing. But we find that if you go into the communities, and I saw someone's just put a question about community care, it's very difficult to accept that type of care for people with chronic illnesses like cancer, especially for the children. There's always this feeling that they're still going to get better. And I'm just wondering if there's any difference, for instance, in St. Jude's and the more high-income countries and for us that are practicing in Kenya and so on.
That's such a good question. If I'm going to answer it in the context of our St. Jude experience. I've been here almost 20 years now. And I will tell you that our motto, it's on the bottom of my name tag, is finding cures, saving children, and that no child should die in the dawn of life. And so when we started talking about palliative care at St. Jude, everybody, the clinicians, the parents, the patients, everyone was like, no, 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 no. So we developed our team name to be the Quality of Life Service when I started. And we now are the koala team. This is our little koala right here that we hand out to all our patients and families. And we talk about issues related to quality of life. We talk about, let's meet the koala team. We try very diligently. You know, again, I mentioned Dr. Lamb is here. We talk to Dr. Lamb and say, you know, Dr. Lamb, get us involved with your patients earlier and earlier. So it's not just about end of life care. And again, you see on my deal here, I use the word palliative care when I'm talking to other clinicians, and I try to teach people about palliative care being about addressing suffering and promoting quality of life. When I talk to families and patients, I talk about our koala and our koala team, and that we're here to make every day the best day it can possibly be. And they have found, even here in the US, that if you simply change the name of something from palliative care to supportive care, that referrals go up. So there is something that is about this that is bringing the team in, and there's just some negative connotation around palliative care. So you have to overcome that. It takes really a lot of effort on your part that you're referring patients, and it takes effort on the palliative care team's part to make sure that we're promoting quality of life, that we're seen as being life-giving, just as Liz mentioned. And I'll tell you that I think the culture at St. Jude, 30 years ago, let's say, was one where everyone would say there's no way that palliative care would ever survive there. And now here we are, and palliative care is thriving. We have a large department. We meet basically every single patient before they die meets our team, and that's and usually 6 to 12 months before the child dies, we meet them. And we're meeting many patients who, as you just referenced, actually go on to be cured. So I think that there's a lot of work to be done in educating clinicians, because I think that's an issue. And then I think what we can do is hopefully remove some of the barriers when talking to patients and families. Palliative care, if that word scares people, then talk about what can we do to make your life full? What can we do to give you the best quality of life? How can we be thinking holistically about these issues?
Okay, maybe an addition.
Thank you very much. Oh, who's that? Is it Zainab?
Yes. I wanted to add.
Okay. Just let me, before you speak, let me just ask anybody who's not speaking, please mute your speakers.
And
Go on, Elizabeth.
I wanted to discuss about palliative care in my country, Kenya. Yes, we have a lot of stigma associated with palliative care. Initially, the palliative care team would come to see a child and a family at the very end. But for us to make the strides that we have made, we start seeing these parents on admission. And we even do photos of before and after where the families can do a comparison. And recently, it was amazing to see families come on and call us and say, I would like to meet the palliative team again, because we are constantly with them on the wards. We visit them every day. So that stigma around palliative care is slowly being erased in Kenya. Thank you.
Thank you. I want to give others opportunity. I think Sonita has actually put, Sonita, is it Sonita? Has put two questions. So Sonti Pilusa. One is that we have, can we talk about any models of care that include self-management and community-based care? The other question he or she asked was, why is palliative care only for cancer patients? And I think Professor Julia has answered that. I think it's just the way we misunderstand what it is. But anybody who wants to talk about the models of care that includes self-management and community-based care? I don't know if you get the question. I don't know if you meant that self-care, or are you talking about the patient's self-management? Maybe you can ask the question, Pilusa. You can ask the question verbally. You can unmute yourself and ask the question. Sonti, Pilusa. Okay.
Zippy, I can try to address something there that I think is a relevant topic. It is very important for a family, first of all, just as Julia mentioned, palliative care, pediatric palliative care is definitively not only for children with cancer, it is for all children with life-limiting and life-threatening illnesses. And so when we think about this, the vast majority of their time is spent in the community. And so we do need to think, again, when we think about the concept of suffering and where that suffering happens, the majority of the time that suffering is occurring actually in the community, not in the clinic, not in the hospital, although it does happen there. We do need to promote care that can be provided in the home setting, in the community-based settings. And that looks different in every community. For us, it took tremendous effort to mobilize a community-based team here in Memphis, but now we have a broad community-based team. But I've been in many models across Africa as well, and in Zimbabwe at a place like Island Hospice, you know, they've really established a wide network across all of the country. And so there are models of care that really should be promoted where we recognize that children's suffering is not only happening in the clinic and not only happening in a hospital. And so we're meeting only a very small percentage of that need if we're not thinking about when they head back into the community and what we can do to support their quality of life in the community.
Yes, and I think that's very important, because even if you look at the WHO definition of pediatric palliative care, it actually emphasizes that it can be provided at every level of care, including at home in the community. So and my former boss, where I started working as a palliative care doctor, used to tell me that palliative care and hospice care is not about mortar and brick, it's about the service itself. It can be given anywhere. So I think Sonita is still saying that she would like to understand what the models, if there are any models that enhance self-management. And I think maybe this is also probably she's talking about self-care, because this is a new concept that has come up really. You know, the patients should be trained, or their caregivers, to manage themselves, so that even when they manage themselves, their health issues, and they manage the health issues themselves, it actually reduces a lot in terms of cost for the patient, for the hospital, and even many other things. So I don't know if that's what she wants us to talk about. Maybe Dr. Justin, you respond to that. Makilan has talked about maybe the way we need to explain what palliative care is we must use the language that the public, the people you're talking to, understand, maybe their vernacular, then they can maybe, agree to have palliative care instead of saying it's about death and dying. But also, so we'll take two more questions before I hand over for the close-up. Dr. Dina Chelegat, and then Deborah, and then Morgan. 3 questions, sorry. And please make them brief.
Okay, thank you very much, members. I really appreciated the presentation. I wanted to just give two comments. One is that we've been reminded today we always try to concentrate on the parents, but today I have learned the importance of involving siblings who go through mourning period. So even in our teaching, we will be able to incorporate that as well. And regarding the community palliative care, we can be able to set up some health information points in the community. If we can be able to do so, then people can come there, get information, and if they are being monitored, as opposed to coming all the way to the clinics, that could be a part of the community management of palliative care. Thank you very much.
Thank you, Dina, for that contribution. You have been a champion for many years. I acknowledge that. Deborah, then we'll have Morgan. Dr. Deborah?
Yes, I was just saying in Kenya, there's been a lot of progress in the community health volunteers. Now, many of the counties are acknowledging them and are even giving them a small stipend. So what we have been doing when the patient is in the ward, just before we are able to discharge them, we are able to call the community health volunteer of their region so that we can brief them on what we have done for the patient and inform them on what needs to be done at home, so that now they're able to follow up the patient even when they're at home. And in case of any complications, they're able to contact us and we're able to make sure that there's continuity of the care, even when they're far from the hospital.
Thank you very much, Dr. Doctor. Thank you very much for that contribution. And Dr. Mida has really remained a faithful advocate for pediatric palliative care, not just an advocate, but a practitioner who has really been, showing the others what they need to do. So thank you. And I hope that most of you are going to be in the APCA conference next week, the African Palliative Care Conference in Kampala, because there will be a lot. Dr. Justin is going to be there. There will be a lot to share and hear about. But before I come to Morgan, there have been many questions about certified child life specialists.
Yes. I expected that. So I have good news for everyone. Liz and I have been undertaking the great endeavor of beginning to offer internships and clinical supervision for child life specialists, not just in Kenya anymore, but also beyond Kenya's borders. And we have 2 active interns right now, one from Ghana and one from South Africa. And we welcome interest and hopefully to be able to offer more in-person internships as soon as our ongoing pandemic is resolved. But Liz and I also do a significant amount of webinars. And what I think would be smart is I will post on my social media the active links to the recorded webinars that anyone is welcome to participate in. Most of them are free and the link will take you directly to the presentation and you can view it often on YouTube. I even have some active facilitated sessions that I've done with World Eye Cancer Hope that are with children and families. So you can actually see me in action and Liz as well, presenting and providing active child life activities that you're welcome to incorporate in your practice. Liz is also quite humble in that we do so much around living and taking the focus off the dying with children that it is legitimately our goal to offer, as soon as a child is diagnosed with any potentially life-threatening illness, condition, disorder, or trauma, that we offer those books about themselves, these wonderful and transformational books about a child's experience. We start those immediately at admission. So there's never a sense like, oh, now this child is palliative, we must introduce this book now about them. It's from the very beginning of their journey and the healing process, of course, of being able to write about themselves, about what they love about themselves, about their journey, and this care within hospital, as well as their life beyond the hospital, is really fostered through creativity. The bead program, of course, handprints, footprints, all these wonderful wish granting opportunities that we do are a part of all the care that children receive from the beginning. So it isn't just distinctly kept for children who we know will be palliative, it's for all children. And then we add additional supports and experiences when we know that there is siblings that need to feel and remain connected to their sibling during their hospitalization and even after death. So there's a lot of wonderful information out there too and free resources. So I'll continue to post those on social media. But Zippy, if you want, I can also send you guys a document with private links, and you're welcome to share them with this group at your leisure.
Thank you very much. That would be great, because Charles and Mishka can share with the group that attended these sessions. We are coming to the end of the session. I would like just to give 30 seconds to each of our speakers to give us their takeaway message. But before they do that, I want to really acknowledge Mishka and Charles, Kenpo and Mishka NCI USA, for having been really behind organizing all these sessions, their patience and their dedication. Thank you very much, because when we start next time, there'll probably be a new group here working with you, but we are very grateful for your support. So we'll give Elizabeth and Dr. Justin 30 minutes each before we hand over to Charles. 30 seconds, not 30 minutes.
Okay, 30 seconds. Hello, everyone again. I feel immensely honored to have been a speaker on this session. For sure, palliative care for children is doable. It doesn't matter where you are, offer that service in the little way you can, wherever you are. It's a matter of living, adding life into those days. It doesn't matter how long that child is, how many years old they are, but they can be old and they don't have life. They can be young and they can have amazing life in them. So let's do that. Thank you very much.
Thank you. It is indeed such an incredible privilege and honor to be here with you all. And my main takeaway from this is that it takes all of us. It takes a village. It takes everybody here, and plus the entire medical and community-based groups around a family to address the many aspects of suffering of these precious children and their families. We all have something that we can do and more that we can do. And I would just encourage you to promote palliative care as a pathway, as a way to address suffering and promote quality of life. Every single child that we see, there's something additional that we can do that would help that day be a better day. So go out and make that difference and promote pediatric palliative care.
Thank you. That's very important. Thank you. I know I said Charles will speak next, but I just remember that if you don't know what ICPCN is, then you don't know anything about pediatric palliative care. So you need to join International Children's Palliative Care Network. As you join in St. Jude's network to understand more about children's palliative care. They also have free courses. There's an upcoming course on pediatric palliative care for humanitarian conditions. So this is very important. Some of you might find yourself working in Kaguma, Dadaab, or somewhere it's it's very challenging. Just check their website, International Children's Palliative Care Network. The CEO is here, Dr. Julia, and join to be able to get free training and more information on children's palliative care. So Charles, over to you.
Thank you, Dr. Zippy. And I would like to thank our speakers for today, Dr. Justin and Elizabeth. Indeed, it was quite informative, and it was an honor to have you today. So thank you everyone for joining us today. We are going to share the recording and the speaker presentations on Basecamp for our reference. And if you're not on Basecamp, you can reach out to Mishka, and you're going to be added there. And you can also access our previous presentations there. So we've come to the end of our Africa Cancer Echo year, but learning does not stop. Our new year starts in September. But moving forward, we are going to have some changes, as Mishka has shared. So we are going to move from bi-weekly sessions, twice a month sessions, to once monthly, but we are going to expand that to 90 minutes. Given that most of the time we don't have to get enough time for discussions. So that is why we thought of maybe having one session per month, but expanding it to 1.5 hours so that we're able to get more time for discussions. So that session will be held that Thursday of every month, starting September. We'll be starting at 4 p.m. Eastern African time, which is 2 to 3:30 p.m. Western African time. And our focus will be based on the core elements of National Cancer Control Plan. And you can see them there: prevention, diagnosis, treatment, palliative care and survivorship, service delivery, health workforce, health information systems, governance, and research and finance. So the specific topics will, of course, be based on this, but will be informed by the evaluation that we carried out earlier. So we look forward to having you here come our next ECHO year. And thank you very much for being part of the community. So I'd like to hand over to Mishka for further announcements. Thank you.
Thank you very much, Charles. Yes, and it's quite a tough act to follow with these amazing speakers today. I will briefly say to you all that I'm pleased to announce the steering committee for the 2022-2023 year of the Africa Cancer Research and Control ECHO. Their names are here in very small print with apologies. We will be chaired in 2022-2023 by Ms. Benda Kithaka, who is here with us today. And Charles, Christine, and myself serve in an ex officio role to help coordinate the steering committee. And Charles and Christine and Kenko are the backbone of this ECHO as the hub. We have the team listed here. In the interest of time, I will not list out their names individually, but I will share these slides after the session today. In addition to this list here, we also have all of the results from the Africa ECHO survey that was conducted, evaluation survey conducted in June. So all of those slides together with the steering committee lists will be going out to you after today. And thank you all to all of those names of people listed here for your service to the ECHO for the coming year. And with that, I want to say an enormous thank you to our outgoing steering committee who created the success of this ECHO this year. Dr. Makalashpikan is our chair. She has served as the chair for 2 years in a row. She served throughout since the pandemic. So this is, as you can imagine, a Herculean task. And thank you to everybody listed here. Many of them you will continue to see on the steering committee moving forward. We can't do this without you. And so your service is, we are incredibly indebted to you to continue this dialogue moving forward. And with that, I thank you all very much. And back to you, Zippy, to wind us up.
Thank you very much. And